Let's type yes. Let's get into today's class. Today's class is going to be great. It's going to be awesome. I'm really excited to come to you, and I'm sure you can hear me clearly. So, today's class, as you know, is about polytrauma. Okay, polytrauma. So, you realize that I'll be sharing my screen, polytrauma, and that will give you a very good understanding about what we're going to cover today. I'm surprised that the words have just changed like that, but it is what it is, It is what it is. Let's continue. So, why I'm dealing with this? Because it's a very, 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 very important MCC objective. And so, if you go into the MCC objective, you realize that trauma is a very important topic. And for those who are very well versed in emergency medicine, you realize that acute advanced life support is very important. And when you get into the MCC objectives as well, you realize that this is a very important topic. So if you want to really ace the exam, if you really, really, really want to ace the exam, then what you want to do is to um, focus on trauma, because trauma is very, very, very important. In fact, what I'm going to do is I'm going to show you exactly where to find that in your MCQ1 objectives. I'm going to just for it and then share it with you so that you really, really come to appreciate it very, very well. So if you go to the medical expert portal, I'm just going to share this screen so that you will see exactly what I am talking about. Okay. So let me go to where I can share my screen, and then you'll be able to appreciate it. So where do I go? Where do I go? Okay. So share screen. Beautiful, beautiful, beautiful. Okay, good. So if you go to the MCC objectives, okay, why am I focusing on this topic? Trauma here. Look at all the topics you need to cover. So you need to, when it comes to trauma, you need to master abdominal injuries, bone or joint injuries. So that is almost all orthopedics, apart from the infectious issues with orthopedics like osteomyelitis and the rest, right? Chest injury. So this is where you're going to talk about flail chest and pneumothorax and all those things. Then drowning and submersion injuries as well. And then you go to facial injuries. Okay, you go to facial injuries, and then you go to hand and wrist injuries. So injuries with anatomy, snuff box, all those things, green stick fractures, all those wonderful issues. Then head trauma. So this is where you get into subdural, epidural, intracerebral hemorrhage, all those things. Then nerve injury, and then skin wounds. How do you manage infected skin wounds? How do you manage simple skin wounds? All those things. Then spinal trauma, and then trauma as a topic that you need to cover. And then you realize that you have urinary tract injuries and then vascular injury. So, doctors, this is a very, very important objective that you can't miss. And that is why I want us to spend some time talking about some very, very important topics so far as this particular objective is concerned. So I want to know, are you with me? If you are with me, just type yes, 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 because this is a very important objective. Like that topic trauma is really big. And for you to be able to ace the MCQ1, you need to know how to go through all these. When it comes to head trauma, cervical spine trauma, chest trauma, abdominal trauma, extremity trauma, all these things, you need to know. And that is why I want us to do an introductory class and really dive into that. So please don't also forget, share the link with as many friends as possible. Those who cannot join us, just I'll be sharing the YouTube link in the comment section. Share it with as many friends as possible. As many friends as possible. And let's get into the game. Okay? Let's get into it. So, trauma. So you realize that the rationale for this, according to the medical council, is that trauma is common. So that is it. In the MCC exam and even all board exams, you realize that common things are tested. So trauma is common, and physicians must be capable. Look at the words very well. Capable of assessing and treating patients with life-threatening traumatic injuries. So you must show capability. You must show um, competence when it comes to trauma. You can't go into any board exam without learning the principles of trauma management. Okay? Now, then we go to causal conditions. So it states that the list is not exhaustive. So you have to look at blunt trauma and you also have to look at penetrating trauma. So blunt trauma, you are looking at things like blast injuries, deceleration injuries. Today, the class will focus on deceleration injuries. Okay? And then when it comes to penetrating trauma, that is when you're looking at gunshot wounds, stab wounds, all those ones. All right. Now, the key objectives. So, given a patient who has sustained trauma, the candidate will diagnose the cause. That's number one. Number two, the severity. Number three, the complications of the injury, and will initiate an appropriate management plan. Please look at it again. Given a patient who has sustained trauma, the candidate will diagnose the cause, number one. Number two, the severity. Number three, the complications of the injury. And number four, will initiate an appropriate management plan. So for each of the various types of trauma, you must know Dr. Shaima Ahmed, Dr. Samuel Olajide, Dr. Rosa Delva, Dr. Marcel Mbaya. All of you must be able to diagnose the cause. Number two, diagnose the severity. Number three, that be able to tell the complications. And number four, be able to initiate an appropriate management plan for every single trauma which comes in your body exam. Okay. And oh my goodness, I don't know why my PowerPoint is like, but we take it like that. So let me see how it will appear. Okay. It's just jumbled up when I moved it to this platform. But you know what? Given a patient with trauma, the candidate will list and interpret critical clinical findings, including those derived from A, great history, which is taken from the patient or lateral. Number two, an appropriate examination performed according to advanced trauma life support. Remember, I said that. And complete primary and secondary surveys in order to ensure that all external evidence of injury is assessed. Okay? And consider the initial management plan. So initiate resuscitation of injured patients and assess the patient's response to resuscitation. Prevent secondary injuries to the injured patient like hypoxia, hypovolemia, spinal injury, and determine whether the patient needs to be referred for specialized care. And as well as part of the enabling objectives, I'm very sorry about the way the slides are behaving tonight, but please bear with me. List and interpret investigations used for the management of injury. So, for example, imaging, electrocardiogram, and keeping in mind that such tests should be deferred if the patient is unstable. So, these are the things the medical council is testing you on. How are you going to, okay, should I send this patient to the CT scanner? Should I hold on? Should I do some resuscitation before I do that? These are the things the medical council wants you to start paying attention to. That is why I say all the time that yes, interesting. It's nice to have your Toronto notes and all those books, but the exam is not testing you on just rote knowledge. It's testing you on practical knowledge. Practical knowledge. So, what is the purpose of today's class? The purpose of today's class is very simple. We are going to match specific injuries with specific mechanisms. We are going to match specific injuries with specific mechanisms because if you understand the mechanism of the injury, then you'll be able to ace the board exam when you are questioned. And you realize that there are so many ways people get injured. And today I'm going to focus on motor vehicle accidents. So when it comes to head-on collisions, what are the common injuries patients get? When it comes to rear end collision, so where one car hits the other, what are the types of injuries people get? When it comes to lateral collision, that is what we call the T-bone. So you have one car going this way, another car coming, hitting it this way, right? So the first one is head-on collision. The next one is one car is moving forward, the other one rear ends it, and then we'll end on with T-bone injuries. These are things we need to learn. And then in future classes, we then go on to rollover injuries, patients who are ejected from a vehicle, windshield damage, steering wheel damage, dashboard involvement, and other forms of injuries that are complex. So we're going to start with the first mechanism, which you must learn and know: head-on collision. Head-on collision. That is where we are starting the game from. And we're going to deal with how do you pick up all these issues in a board exam. So let me give you the first question. So you have a 30-year-old restrained driver in a high-speed head-on collision, presents with severe chest pain and hypotension. Two things: severe chest pain and hypotension. The patient who had a head-on collision. Chest X-ray shows a widened mediastinum. What is the most likely injury? Doctors, what is the most likely injury? A. Pulmonary contusion. B. Cardiac tamponade. C. Traumatic aortic transection. D. Myocardial confusion. And E. Tension pneumothorax. In other words, this question is testing your knowledge on how each of these five options will appear on X-ray, and what is the mechanism which will help you to know: is this a pulmonary contusion? Is this a cardiac tamponade? Is it a traumatic aortic transection? Is it a myocardial contusion? Or is it a tension pneumothorax? What's the correct answer? I see a lot of doctors going for C, which is traumatic aortic transection. Now, what is the answer? The correct answer is C, traumatic aortic transection. Again, please forgive my slides. I don't know what is going on today, that the slides are behaving this way. Please forgive my slides. I don't know what happened that they are behaving this way. Okay, keep the slides today, but we'll still learn nonetheless. Okay, so why is that a correct answer? When you have a patient who is in a car strained and there's rapid deceleration in head-on collisions, it causes tearing at what we call the ligamentum arteriosum, and that is the classic site of aortic tears. Ligamentum arteriosum. So you realize that I've put in an image. Ligamentum arteriosum. Ligamentum arteriosum is like the remnant of the patent ductus arteriosus when the baby is very little in the mother's womb, right? Now, the patent ductus arteriosus then closes and then leaves what we call the ligamentum arteriosum. So the ligamentum arteriosum serves as like a hook. So look at this. The aorta is in the chest. The aorta has some mobile part and immobile part. One of the immobile parts is the ligamentum arteriosum. Now, just imagine a patient who is sitting in the car at high speed. Boom! Then there is collision. When there is a collision, the part stationary, which is the ligamentum arteriosum, stays, but the rest of the part of the aorta moves. Now, when it moves, the ligamentum arteriosum is holding it back. Meanwhile, the part of the rest of the aorta has moved, and that is where the shearing force can occur. So you realize that the ligamentum arteriosum is linked to aortic transection because it serves as like it serves as a hook. Okay, so if you look at the picture I've sent you very well, it serves as a hook. and it creates a fixed point on the aorta. And when it creates that fixed point on the aorta, what happens is that in a high-speed car accident, the other part of the body will decelerate and it causes the mobile part of the aorta and the heart to move forward. But the ligamentum arteriosus is holding it backwards, right? And that is where the shearing force will occur. And then that is where the transection will occur. Doctors, please, I have a question. Does that make sense? I want to move on to the next thing. But before I do that, I want to make sure that this makes a lot of sense to you. Ligamentum arteriosus. So it's not just something we are just guessing. There's a principle behind why we are choosing aortic cord transection because of the shearing force which occurs, and the ligamentum arteriosum is holding things back, but the rest of the aorta moves forward, and then it causes a tear, and we are in trouble. Please, does this explanation make sense? I want to really know. Does the explanation make sense? Yes or no? Yes or no? Good. Very clear. Very, very clear. Thank you very much. Very clear. So the Joanna says it's very okay. So this is how chaotic transection will look like on chest X-ray. That is why the question said that the mediastinum is wide. All right. Okay, good. So yeah, the symptoms will be basically the patient will have chest pain, and because of the transection, what can then happen is that they can also be bleeding. The bleeding can lead to hypotension, and the patient can get into shock. Next question. Next question. Which of the following injury patterns is most characteristic of a high-speed head-on collision? So the following injury pattern is most characteristic of a high-speed head-on collision. A. Hyperextension of the cervical injury. Hyperextension cervical injury. B. Central cord syndrome. C. Posterior hip dislocation. D. Lateral rib fractures. And E. Pelvic avulsion injury. So the following injury patterns is most characteristic of high-speed head-on collision. In other words, you can have a lot of these options as correct, but which of them stands tall when we are listing head-on collisions? Which of them stands tall? A. Hyperextension of cervical, hyperextension cervical injury. B. Central cord syndrome. C. Posterior hip dislocation. D. Lateral rib fractures. And E. Pelvic avulsion injury. So I see some going for A, which is hyperextension cervical injury, and others going for C, which is posterior hip dislocation. The Scheimer went for pelvic avulsion injury. Now, what's the correct answer? The correct answer is posterior hip dislocation. And Dr. Rockefeller, I will come to the issue of the hyperextension injury. You realize that the hyperextension injury is common in rare end. So one car is one car hits it, and because that's there's hyperextension injury. But I'll come to that. So we are saying that all those may be likely, but the most likely is posterior hip dislocation. Why? Because of what we call the dashboard injury. Okay, so when there's head-on deceleration, the car is moving quickly, boom, and then it comes to a stop because of the accident. There's posterior hip dislocation and lower limb fractures, and I'm going to explain why. So just think about it. You have a sitting in the front seat, and that is why I've put that picture there for you to be able to appreciate it very well. Okay, the patient is sitting in the front seat. The two cars hit against each other. The person's leg hits the dashboard, and then because of the force which is coming from in front, now it moves the leg to the back, and that leads to posterior hip dislocation. I'm going to show you another picture. This even makes it more clear. So the person is moving, it's a head-on collision. The knee hits the dashboard. Boom! It's moving. Doctors, please, are we all on the same page? I want to know. Are we all on the same page? Posterior hip dislocation. Most likely. Most likely. That does not mean that the rest of the injuries can be okay, but each of them is mostly associated. Beautiful. Nova says yes. Okay. So, what's the teaching point here? In head-on collisions, the mechanism is rapid deceleration. So the car was moving quickly, and the car comes to a rapid stop. So there's forward motion of the torso, and it is also halted by restraint. That is the seat belt that the patient is in, or the steering wheel, or the dashboard. And because of the way the injury occurs, it can lead to facial injuries, it can lead to chest injuries, it can lead to lower extremity trauma. Okay, so now let's look at the various parts of the body which are usually affected so far as head-on collisions are concerned. So when it comes to the face, the patient can develop facial fractures or lacerations. And most of the time, it is as a result of airbag or steering wheel impact. So airbag or the steering wheel impact can affect the patient. When you go to the lower extremity, it can affect the femur, it can affect the knee, it can affect the tibia, and most likely there can be posterior hip dislocation. So I need you to write this down in your book. Posterior hip dislocation. And this occurs as a result of dashboard injuries. So the knee striking the dashboard, and because of the force, it pushes the hip back, and then the patient can develop a posterior hip dislocation. And when it comes to the aorta, there can be aortic transection, which we've learned from ligamentum arteriosum, the sharing force of it, okay, because of the rapid deceleration. Doctors, please, can I move on to the next one? I want to make sure I move on. I want to make sure that it has made sense before I move on. Please, can I move on to the next slide, please? Hello, doctors, please, can I move on to the next slide? Okay. All right. So let's go on. So now that we are done with the head-on collision, let's go to rear end collisions. So doctors, you see, these things, they are very, very practical. And that is why I always say that when you're preparing for a Canadian board exam, you need to be extremely practical, right? You need to think like a Canadian doctor. And so when it comes to the Q1, don't forget, never ever forget your Tensinali. That is the book you need for for emergency medicine. Okay, I carry my Tensinali around all the time. Let me look for my Tensinali and show it to you. Okay, let me just look for my Tensinali. Okay, so if you want to ace your emergency medicine board exam, so far as the MCQ one is concerned, this is the book the medical council recommends. This is the book. And this is what those who are writing the plus one exam in emergency medicine, this is what they study. And that is why I'm always talking about it. But you don't need to read the entire book. I have done everything for you in the program. So you can easily get it and study. So let's go to rear end collisions. So those who want a copy, you can also can get it intentionally. They have the just for just the fact. And if you're able to master this, no emergency medicine portion of the exam will be. No emergency medicine portion of the exam. So now let's go to the rare end. Okay, so we finished the head-on collision. Now let's go to the rare end collision. So you have a 42-year-old man who is involved in a rare end collision, presents with neck pain but no neurologic deficit. Which mechanism best explains his injury? A. Hyperflexion. B. Hyperextension. C. Axial loading. D. Lateral bending. And E. Rotational shear. What's the correct answer? 42-year-old gentleman involved in a rear end collision presents with neck pain but no neurologic deficit. Which mechanism best explains his injury? A. Hyperflexion. B. Hyperextension. C. Axial loading. D. Lateral bending. E. Rotational shear. Okay, so Dr. Rockefeller is saying B. Whiplash injury. So you see why when we're talking about the head-on collision, I was like, you want to be careful about that answer because it will come up sometime. And the correct answer is B, hyperextension. Okay. So when there's a rear end collision, okay, just think about it. So I'm sitting in a car, another car hits my back. What happens? It moves my car forward and then my neck goes backwards. It moves my car forward and my neck goes backwards. So that is the hyperextension. So the rear end collision, there's sudden acceleration and it leads to neck extension or whiplash. So I'm just going to show you a picture so you see the mechanism very, very well. Okay, see the mechanism. So the injury is coming from the back, and because it came from the back, the patient has to hyperextend the neck because it looks like the force is moving the rest of the body forward, and then the neck goes backwards, right? Mm. And usually in hip latch injury, what happens is that there's a torn anterior longitudinal ligament. That's where the problem comes from. That's where the problem comes from. Okay. So another question for you. You have a 35-year-old woman who presents after a rare end collision. She complains of neck stiffness and hospital headache, but no neurologic deficit. What's the most appropriate initial management? A. Immediate neck flexion exercises. B. Applications of collar analgesics. D. Urgent staphylectomy. D. High dose corticosteroids. And E. Traction therapy. Right answer. So anyone who is involved in a motor vehicle accident, what will you want to do? You want to apply a cervical collar because whiplash can result in injury and therefore immobilize care to the patient. Okay, awesome. Okay, so that is a patient cervical collar. I just decided to bring these pictures so it can remind you. So in your board exam, you remember that Dr. puts these concepts to everybody, IMG community, the Canadian Medical Group community as well. Okay, mechanism. In a rare end, the body is suddenly accelerated forward, the rest of the body, because the near back. So, who, while the head will lie. So just imagine this. Okay. So just imagine that body comes forward, head goes back. That is how the whiplash injury. Now, the rebound flexion may also occur, which is what we call the whiplash move. So the body will go backwards and then come forward. Right? So the body will go backwards and then come forward. That is how the whiplash motion occurs. and common in low to moderate speed vehicle impact, especially when the headrest is low. So you see that in this chair of mine, the headrest is a bit high, but there are some cars that the headrest is a bit low. So when the person goes back like the neck may apex, and that can really, really cause a lot of trouble. Okay. So let's look at some very important things. So when there's a rear end injury, there's hyperextension injury, where there's initial backward bend of the neck due to the sudden acceleration of the rest of the body. Now, which vertebrae is affected commonly? C5 to C7. Please, I need you to write this down. These are hard facts that you must know. C5 to C7 most often affected and may be associated with ligamentous injury. That's what I showed you in the picture. And there can also be central cord syndrome, which occurs mostly in elderly people who have cervical spondylosis. Okay, so the hyperextension causes the gray matter in the spinal cord to get injured. And the feature about central cord syndrome is that there's more upper limb weakness as compared to lower limb weakness. So the upper limb weakness is more than lower limb weakness. So if you have a case where you get a patient, maybe even in your medical practice, you get a patient, an older gentleman in a rare end accident, now you do examination, looks like the weakness in the arm is more than the weakness in the leg. Please think about central syndrome. So in central cord syndrome, the weakness in the upper part of the upper limbs is more than the weakness in the lower limbs. And there's variable below the lesion. Remember that I said the commonest place. What's the commonest place in the vertebrae where this place? What is the commonest place in the vertebrae where the effects rear end lesion can occur? I want an answer. I want to see an answer. Make sure that you guys are listening to me tonight. I know it's late, but it's a pleasure to see that all of you are joining us live, right? It's a pleasure to know that all of you are joining us live. So, which part of the vertebrae is most affected? Beautiful, Dr. Benedicta, C5 to C7. Okay, so now central cord syndrome, which as a result of rare end collusion in older people, the weakness in the upper limb is more than the weakness in the lower limb. Variable sensory loss below the lesion. There can be bladder dysfunction, and neurologic deficits may worsen with neck tension. That is why you want to mobilize the neck immediately. You want to mobilize the neck immediately. Okay. Doctors, I have another question. We've done head-to-head collusion before you go to bed tonight. We've done head-to-head collusion. We've done rare end accidents. Please, does that make sense so far? Before we go to the third mechanism tonight, the third mechanism, because you need to know these mechanisms by heart so that in your board exam, you know exactly where we are inquiring you to, know the points from. So, head to rare end. Now we're going to T-bone. T-bone. So just think about the word T. So the red car is serving like the top part, and then the black car is serving like the long part of the T, right? So the problem is that it's the black car which has gone to hit that side of the red car, and that is why we call it T-bone collision. So let's try some questions. A 42-year-old man involved in right-sided T-bone collision complains of abdominal pain and shoulder pain. What's the most likely injured organ? Right-sided T-bone collision. A. Spleen. B. Liver. C. Diaphragm. D. Kidney. And E. Colon. What's the correct answer. Please tell me what's the correct answer. What's the correct answer? Doctors, what's the correct answer? So a lot of people are going for B. And the correct answer is B. Right-sided lateral impact can lead to liver laceration, right? And the liver laceration can then lead to referred pain to the shoulder through the phrenic nerve. So you ask yourself, why are we putting right-sided injury alongside shoulder pain? Because of the connection between the phrenic nerve and the mechanism of injury. Okay, next question. In a lateral motor vehicle collision, which of the following thoracic injuries is most likely? In a lateral motor vehicle collision, which of the following thoracic injuries is most likely? A. Flail chest. B. Clavicle fracture. C. Pulmonary embolism. D. Pneumothorax. And E. Aortic transection. So just think about it. I'm sitting in a car. I am T-boned. I'm T-boned from my side. So the following thoracic injuries is most likely. Which of the following injuries is most likely? Well, Dr. Rockefeller is saying flail chest as a result of injuries to the rib, but the correct answer is clavicular fracture. Flail chest can also happen, but the direct side impact, okay, frequently causes rib and clavicle fractures due to compression against the door frame. But when it comes in between the two of them, the clavicle fracture is more likely. So the flail chest can be correct, but when you have clavicular fracture, because of the way the clavicle is situated, that is more likely than the flail chest. Okay, the flail chest will also occur in a T-bone injury, but then the clavicle fracture is more likely. Okay, next question. You have a 40-year-old man who presents after a T-bone collision. He has right upper quadrant tenderness and elevated AST and ALT. What's the next best imaging study? A. Chest X-ray. B. Fast ultrasound. C. Head CT scan. D. MRI of the abdomen. And E. Barium swallow. You have a patient, you are in the emergency room. The patient has right upper quadrant tenderness and elevated liver enzymes. What's the next best imaging study? What's the next best imaging study? You're going to get a fast ultrasound. Fast ultrasound is done by emergency physicians in the emergency room. They carry ultrasounds around and they scan a lot of people. It is the fast ultrasound, which is the focus assessment with sonography for trauma. It's the first line to detect intraperitoneal fluid, like liver injury. Okay. So, Dr. Rockefeller, you want to review your answer again. Fast ultrasound. Okay. So, the collision mechanism in a T-bone injury occurs when a side of a vehicle is struck in a T-bone fashion. So that's what I was saying. Okay. The first injury we learned was head to head. The next injury we learned was back, front to back. Now we are doing front to side. Okay. And minimal structural protection is seen at the doors. Okay. A lot of the structural protection is at the front where the airbag bags are deployed. Okay. And direct energy transfer to the outpatient's thorax, abdomen, and pelvis. So injuries depend on the side of impact. So if I tell you that, like in a regular, normal driving Canadian car or cars that we ride in Canada, if the injury occurs on the driver's side, the T-bone injury, That means the left side is going to be affected more than the right. So you're thinking about left clavicular fracture, you're thinking about left rib fractures, you're thinking about splenic injury because the spleen is on the left, right? Meanwhile, if the person is struck on the passenger side, then that's a different ball game altogether. Likely that the liver will be affected. So, plus, when it comes to the T-bone injuries, the thorax, you have pulmonary contusion, rib fractures, clavicular fractures, humeral fractures. Don't forget that as well. And the mechanism is when there's lateral compression of the chest wall. Okay, when the chest wall is compressed laterally, that's the problem. And then when it comes to the abdomen, there can be splenic injury on the left side. So if the question says the person was T-boned on the left, splenic injury is more likely. The person was T-boned on the right, then the liver injury is more likely. So that's a result of direct compression of upper abdomen against the ribs or the seat belt. And then when it comes to the pelvic injuries, there can be pelvic rim fractures, acetabular fractures, okay? And it's as a result of the lateral impact transmitted through the hip and the pelvis. And the clavicle and the humerus fractures, they occur from side impact or bracing, okay, against the force which is coming. So, what are the clinic pearls of T-bone injuries for your MCQ1 exam? If it is left-sided impact, think about splenic injury. If it is right-sided impact, think about hepatic laceration. And you must have a high suspicion for thoraco-abdominal internal injury, even if the external trauma appears minimal. And you also realize that seatbelt and airbag use may not fully protect against lateral force trauma. Okay. So now that we've dealt with these three mechanisms, we're going to do our active recall. But let me see. Dr. Rockefeller says, Dr. Boni, what injuries are seen in the striking vehicle as opposed to the vehicle that was struck? So for me, the vehicle that struck, a lot of the injuries in the people will be like the injuries in head-to-head collision. But then the vehicle which is struck, a lot of the injuries depend on where the passenger was sitting. Was the passenger on the front passenger side, or was the passenger on the driver's side? But before we go on to the active recall, I want to let you know, why should you choose Medcognito? Right? We are very focused on your success. We really care about you. That's the first thing. So all the doctors who have been in our program will testify to that. Number two, you're also going to get a lot of support in our WhatsApp group. So you have a private WhatsApp group for QE1 takers, and it is only open to those who have registered to take the program with us. Okay. Number three, you will have a question bank. You cannot go into this exam without practicing as many questions as possible. Number four, you're going to get the content on your own laptop. You'll be given a login detail and you'll get it on your own laptop. Number five, you get what we call med bullets. So med bullets is like the notes that you make for your final revision, right? Now for this exam, we've done it for you and we've done it in video format. And so you can take advantage of that. And then number six, we also have what we call med drills. So med drills is like a fast-paced revision course, like a drill, right? That you can do. We usually plan to do one. We do it monthly. And when the exam is also approaching, we can also do some more med drills. So doctors, this is what you are in for. And by registering and taking advantage of the promo that we are doing right now. So instead of paying $2,520, you are only paying $1,997 right away. If you contact me right after this class and you want to take advantage of it, boom, you get it. And then number seven, you also have mock exams. So you have mock exams in your portal that you try at home at your own pace. And every 2 weeks, we also conduct a mock exam for everybody, whether you're a med cognitive student or not. Okay? Or not. So these are the issues. This is why it is great to join med cognitive. So let's do some active recall. You have a patient who was T-boned. There's left side impact plus hypotension. What organ is affected? Or what is your diagnosis? What is your diagnosis? T-bone collision on the left side with hypotension. What is your diagnosis? No. Beautiful. Dr. Sarah Maddy says splenic rupture. Splenic rupture. Splenic rupture. On the left, you're looking at splenic rupture. That is it. Simple. So you see, now we are building connections. We are building connections. Okay. T-bone collision on the right side with elevated liver enzymes. What's our diagnosis? T-bone collision on the right side with elevated liver enzymes. What's the diagnosis? Doctors, what's the diagnosis? What's the diagnosis? Hepatic injury. Beautiful. Hepatic laceration. Okay. T-bone collision plus shoulder belt restraint plus upper chest tenderness. What's the diagnosis? There's T-bone collision plus shoulder belt restraint plus upper chest tenderness. What is the answer? Okay, so the answer is clavicular fracture, right? Clavicular fracture. Okay, next question. You have a patient who had rear end collision. The patient is older and the arms are weak more than the leg. What is your diagnosis? Older gentleman, arms are weaker than the leg. What's your diagnosis? Doctors? Beautiful. Central cord syndrome. So Dr. Ronnie Lankela got it right. And Dr. Lankela has aced this QE1 so beautifully. So that's a central cord injury. We learned that today. Okay. So next question. You have a patient who was rear-ended. Where in the cervical spine is the body most mobile? The cervical spine. Where exactly is the body most mobile? Where is the body most mobile? Where is the body most mobile in the cervical spine? C5 to C7. Beautiful. Dr. Rockefeller. Now, head-on collision plus dashboard impact. What usually occurs? Head-on collision plus dashboard impact. Head-on collision, and there's a collision with the dashboard. What diagnosis are you going to suspect, please? What diagnosis are you going to suspect? Head-on collision, and there's issues with the dashboard. Beautiful. Dr. Ariel Bola says posterior hip dislocation. That is it. So it can be posterior hip dislocation or femur fracture. Because don't forget, the patient got hurt, and then the patient's leg went into the dashboard. Okay. Rapid deceleration with widened mediastinum. What's the correct answer? Rapid deceleration with widened mediastinum. What's the correct answer? Rapid deceleration with widened mediastinum. Rapid deceleration, wide mediastinum. What's your diagnosis? Rapid deceleration plus wide mediastinum. Good. Traumatic aortic dissection or transection. Beautiful. So doctors, please. I've brought an end to tonight. I knew that tonight is long. I don't want us to waste too much time. And that is why I've kept those 3 mechanisms. So please reason through it. And as I said, the other mechanisms that you need to master, okay? The other mechanisms that you need to master. The other mechanisms that you need to master. I'm just going to show you. So head on, rear end, lateral. What about roll over? The car rolled over. And what about if the patient was ejected, right? What about if there's sharing forces? Okay, so these are the things I want you to pay particular attention to for your board exam. Okay, so if you want to get in touch with me, I'm available tonight before I go to bed at +1 306 891 5649 +1 306 891 5649. Reach out. So someone says, aside CAMS and Medcognito questions, do we need extra Q banks? I would say that a Q bank you need to absolutely get is the MCC's own question bank that you need to buy from their portal and try. Okay, if you can do that, that will give you a very good gist. So whatever other question bank you want to use, great. But don't forget that in Medcognito, you have a question bank on top of everything you are getting. So if you want to talk to me and jump on the program right away, my phone is ready. +1 306 891 5649 +1 306 891 5649. I hope you are relaxing. And you can have a good night today. +1 306 891 5649. So remember, it's only 1,999. Someone has already sent me a message. I'm going to call the person as soon as the class is done, and then we jump on there. Remember, the Q1 classes are every Thursday evening and every Sunday evening. Okay, every Thursday and every Sunday. So thank you very much for making time for us to discuss these very important mechanisms. When it comes to the rest of the mechanisms, I'll make sure that whenever we are doing a trauma topic, we bring it up and then we discuss more. Thank you very much. +1 306 891 5649. Call me right away before I go to bed and let's have a conversation. Bye-bye. Bye-bye.